Welcome everyone to the SAB's May educational webinar, Single Anesthesia Event for Lung Nodule Marking in Minimal Invasive Resection with Drs. Abdul Alraiyes and Cedeño-Rodriguez. Before we begin the presentation, there are just a few reminders. You all have joined in a listen-only mode. You may ask your questions by submitting them through your control panel. Please find the question feature or use your chat box. We will address all the questions after the lecture and during the Q&A portion. Dr. Hussam Nayef will be moderating tonight's session, and he sits on the SAB's Program and Education Committee, as well as is the chair of the Industry Relations Committee here at the SAB. At this time, I'll hand it off to Dr. Nayef to get us started.
Welcome everyone to the Society for Advanced Bronchoscopy educational webinar. Your host today, Hussam. We present to you on a monthly basis discussions and reviews in advanced bronchoscopy and interventional pulmonology. Today we have an exciting topic, as Emily had mentioned, single anesthesia event for lung nodule marking and minimal invasive resection by Dr. Abdul Alraiyes and Dr. Alex Cedeño. I have the honor today to present to you both speakers who are well known in the field of interventional pulmonology and thoracic surgery. Dr. Abdul Alraiyes is an interventional pulmonologist at Advocate Health. He graduated from Aleppo University in Syria and completed residency in anesthesia in Riyadh Military Hospital in Saudi Arabia, as well as internal medicine residency done at Case Western University. He completed his sleep fellowship at Case Western University, the pulmonary and critical care medicine fellowship at Tulane University, New Orleans. He finished his interventional pulmonology fellowship at Cleveland Clinic Foundation in Ohio. He is a member of the board of directors and the chair of communication committee at the AAVIP. He is a member of the interventional chest diagnostic procedure committee and the vice chair of the innovation education committee of the American College of Chest Physicians. He chaired the AAVIP and CAQ board review course and currently a member of the program organizing committee for the AAVIP conference for the past 5 years and a sub-member since 2018. Welcome, Dr. Abdul Alraiyes. Dr. Alex Cedeño-Rodriguez, he's a thoracic surgeon. He specializes in adult thoracic surgery with a special interest in tracheal surgery, minimal invasive and robotic thoracic surgery, as well as extracorporeal membrane oxygenation support for the lungs. Dr. Cedeño earned his medical degree from the University of Puerto Rico School of Medicine in San Juan, Puerto Rico, where he also completed a residency in general surgery. He also had completed his fellowship in cardiothoracic surgery at Albany Medical Center in New York and advanced training in tracheal airway surgery and ECMO at New York Presbyterian Hospital, Columbia University Medical Center in New York City. Dr. Cedeño-Rodriguez is board certified in thoracic surgery. Without further ado, I'll give the mic to our speakers.
Thank you, Hussam and Emily, and thank you for the SAB for the invitation. It's an honor to be a part of this webinar, and we apologize for the messy room behind us, but it's what we do every day and where we discuss these topics. The same thing, the OR room is always messy when you have two procedures happening at the same time. And as Hussam mentioned, that we are going to cover that single event. That's the main core of the talk, how we mark the nodules in the same day of a procedure that has advanced diagnostic and thoracic surgery in the same room for the procedure. As a disclosure, I'm a consultant for Intuitive, but we are also the presenters, and the content of this presentation is our responsibility slot. So the objectives, my part of the talk gonna cover the lung nodule marking for minimal invasive surgery, but more important, how we include real-time imaging for that. And then we'll answer 4 questions: why we need to mark it to start with, and when to do the marking, and how to mark, and where we should mark. That the most 4 questions that can be answered, I think, will cover the part that I do from the procedure. But the most important, highlighting the importance of the collaboration between IP and thoracic surgery for this type of procedure. So now we are dealing with the advancement of the technology that 10 years ago when I graduated from fellowship, we were like really going after nodules that size of an egg or lime, or when we go after 10-millimeter nodule with other technologies, we were like so happy if we get diagnosis. But now with the advancement of all of this, we're moving to a new era where small nodules that next to a very critical organs or blood vessels now in the catch of our hand. And you know, with the advancement of both real-time imaging and on top of that also the robotic bronchoscopy in general, with the advancement of the navigation system overlaying those two together, those targets become more handy to get. But now what we should do when we diagnose patients and when they are in a very early stage, it's great to do that. But now we are responsible about the next step when you call the patient with 8-millimeter, 10-millimeter lung nodule that positive for cancer. The history of lung nodule marking starts, and I'm highlighting one of the great paper by Dr. Harris that shows a really summary of the history of this marking. And as any procedure started in the lung by interventional radiology, percutaneous, it's moves toward the endobronchial as we live this era now. But first, what we use for those marking. In this paper, he highlighted multiple of the dyes, including methylene blue, barium, ICG, and others, plus the use of hook wire on that. Multiple of those lesions were marked by IR with the hook wire, and then so regular coil or metallic fiducials. So percutaneously from this paper, excuse me for that busy slide, but as you see, majority of the percutaneous done by the hook wire, and all of those lesions were mostly in the size of 10 to 20 millimeter, and also those marking happen the same day. They use also indigo caramel and also the barium in some cases, but we were talking about the era where the VAT was the way to resect, and also fluoroscopy is an option to resect. So that's why the barium and the hook wire or the coils were one of the options that can be used, because you can see them with a fluoro when you are resecting by the surgery. However, as we know from percutaneous localization, from even the biopsies, we were looking at this data that shows really reaching a level of 60% of pneumothorax for some cases, especially when the hook wire was used, and also bleeding was high, about 41. And they reported because of that, some of those lesions were ground glass opacity. So the marking were more harm than help to find that lesion when this happened. The other thing that happened, which is also because you are moving patients from room to room after procedures, the dislodgement of the hook wire from the location by 9%. Of the same paper, they describe also comparison from the percutaneous to the endobronchial. But in this model, as you see, there was more use of different type of dye. And they really started with the barium, and that the only one that used to do the marking in more than one day, not the same day of the procedure. And again, they used it with the coil or the barium. The maximum was like 7 days from the day of the procedure. And then they described that all those procedures done, getting the answer, but there was some side effect, no complications like pneumothorax or much bleeding, compare that it was some of them gave a diffuse signal up to 8 to 10%, and all those combined their studies. And there was also about 2% that the signal lost, and most likely, as described, because the injection of that dye went into a blood vessel and then went at the stream of the circulation and did not stay in that area. Again, they used the fluoroscopy as support to know where is this localization, especially with barium, and they used also mainly VATS. Another use of implementing coils started on 2010 by Dr. Linden, and it was mainly for SPRT. It was not used by that for a goal of resection. However, it was more labeling tumor for SPRT, and they used navigation system. There was reported with that 52 cases. They used small coils, 1 to 5 millimeter coils, and that helped only for that. However, because I think that the type of navigation used, there was increased risk of pneumothorax, and the coils ended outside the lung in 5% of those cases. So now, having that history, we were looking at why we are doing this. What's the goal from marking? Apart from doing this procedure to help that seeing that lesion, know where it is and mark it, but more guidance to achieve a good resection with reservation of as much as we can lung tissue. And based on the recent studies, but I will cover one of them, Dr. Cedeño will be covering most of them. I will extract how we implemented the protocol from this paper, everybody aware of it, about lobar versus sublobar resection, that shows a good mortality equal from lobar versus sublobar when done for patient with 1A stage. So from that paper, we implemented that patient who will be included on any marking procedure should be really less than 2 centimeters. Above 2 and above centimeter should not be the case, especially if this not subpleural, if it's really inside a little bit, because that's where we are hitting a target that not can get the free margins. The second thing is we have to make sure we have a diagnosis before we do that, and make sure that small non-small cell, as said from this study. And then also make sure we have a staging, because if we don't have the stage, that will be almost doing a surgery for somebody, and then we find out during the surgery after that you have some lymph node metastasized. So it's a must that the patient goes for staging during the diagnostic procedure. Any nodule diagnosis, the patient lymph nodes should be evaluated. But that's also put a pressure, as everyone know, on the pathologist to give answer in the spot. So it's not logic to try to put the coil or any marking during that time without having proper staging and getting the final answer. Most of us, at least in 20 to 30%, the diagnosis or the staging changed after finishing the case and getting the final diagnosis. So that's why we don't implement that kind of marking until we make sure that we have the final answer, the PET scan completed, and we know that the idea is to reserve lung tissue for sure. That's why PFT and surgical clearance were already optimized, and know that the patient undergoing a good condition to achieve the goal that this paper provided us with information. So when we should mark the lung nodule, and should we do it in a single event anesthesia, or versus if we can do it in other events? And that's, as we know, we're changing that between having a procedure done in 2 occasions, maybe 2 anesthesia events versus 3 or more. So, and if we are implementing this as our goal to diagnose, and we have a patient who has a lung nodule that he went for a biopsy, got the diagnosis and the staging, and then we got the answer, and then we completed his clearance, his PFTs, and everything. And you are working in a different hospital that you don't have the same time collaboration or connection with a thoracic surgery to see if you can time the procedure the same day. What happened is you have to do the marking in different day. And then based on that marking, then the surgery happened. So even with the best scenario that if you get the diagnosis in the same day with the staging, and you have the PFT, and you did the marking, and then you went for surgery, you are going for 3 anesthesia events. That's the best scenario, if not diagnosis and staging happen in 2 different times. But that also costs time, because what's happening here, we have to book the patient for either visits or appointments or procedures that will have time to fit on the schedule of different, either the advanced bronchoscopist or the surgeon. On the other hand, if the diagnosis happened and you are staged the patient and you have the clearance, you are clearing the patient now for marking and surgery. So in the model that we have here, we do the diagnosis and staging in one, we get the final result, we go over the result, make sure that we have the staging, MRI of the brain, PET scan, clearance for surgery, and then we plan the marking and surgery. I'm not saying this is the ideal for every practitioner or every physician, but I'm trying to present that model to show that where we can maybe save time to. So the other thing is, there's a good point that we might say it's 2 anesthesia events, but at the same time, the marking and the surgery might take longer time than if you do marking alone, and then the surgery would be the same. So still, you are bringing the patient for 2 schedules that happen in shorter time. So if we are placing the fiducial or the marking or any kind of marking that lasts long for a long time, and at the same time of the diagnosis, that's another thing if you want to save the time for the patient. There is a risk that we are putting the pathologist at higher pressure, that they have to give us answer about, number one, the diagnosis of the nodule, make sure it's non-small cell from that rows that we give them on the slide, either from TBNA or from a touch prep from a biopsy. At the same time, we are asking them to give us an answer from each lymph node that we think it might be enlarged that need biopsy, to make sure the staging done at the same time. And then we are marking a lesion that might change to be small or non-small cell. And then the second thing, we are prolonging the procedure, because if we will be waiting for each slide to be read to make sure that we are cleared from the first, the preliminary result can change 20% of the time or 10% of the time. I don't have the exact data. But then you are also marking a patient that might have an abnormal PFT if you don't have it before that procedure. If you did the PET scan before, that's great. But if you don't, that's another risk that we will higher the risk of late marking a patient that might not be surgical if there's another metastasis somewhere. And also the patients might have another conditions that he tolerate anesthesia from the diagnostic part, but he will not tolerate anesthesia or even resection based on cardiac situation or something like this. So really, we should be very careful that when we are selecting, when we are doing the marking, and if the marking was placed without a not good communication, with discussion with the thoracic surgery to know when exactly the surgery will be done, there's a risk of fading the mark and fading the signal. So putting all that together, from our experience with the single event marking, the diagnosis is completed. The patient knows the stage before the procedure. We know that we discuss with him the outcome of the surgery and what we will be expecting the day of the marking and the surgery. And all those checkpoint about PET scan, PFT, cardiac covered. The patient also knows that he's doing 2 procedures in one. And the most important, that what I found it really very helpful to work with amazing colleagues, that we discuss the cases to know where we should put that marking for that nodule. I learned a lot from that, and that would be covered by Dr. Cedeño later, but I'm really highlighting that benefit from it. So where to mark, that's what we do it in one OR, number one, as a location where the marking happened. And we have roughly data that the marking, if you're doing one marking for one lesion, or if you're doing more than one, it can go from 20 to 40 minutes. Then the robot, the diagnostic robot goes out, the patient positioned with A-line, fully catheter, tilted to the side, take 20 to 40 minutes. And then the significant advantage is the shortening time of the either segment sublobar resection in general. But what we learned that where to put that, the marker in general, whatever, if it's injection, if it's coil, if it's whatever we are using, more important to study the relationship between the pleura and the lesion. And more important that what we're learning is to have the lesion, the marker leading toward the lesion from the where is the cut coming from. That what will help preventing either getting a positive margins or even avoid the resection of larger size. By saying that, we should also understand how the lung behave when it's collapsed and where is that cut coming from that provided by the thoracic surgery before the surgery. So from our experience with that, if we have a lesion that's 2 centimeters away from the pleura, if we place any marking within, even the same day, within that lesion, the signal is not good. The second thing, that if you place it with on the proximal, so any robotic or navigation system will lead you toward the lesion. The problem is if you place it in the proximal end, where the airway ending next to the lesion, you have a risk of losing the signal too. So what we saw in that case, we have to create something as a phantom target. And the relationship between that phantom target and the nodule is related to the next pleura next to it. So at least to have the marking within 1 centimeter from the proximal pleura. At the same time, we should not put it randomly in any pleura that we see. This is where the money comes from if you have the ability to discuss with the thoracic surgery, because we look at the X-ray and the CAT scan in different dimensions that the patient is when he's positioned for the resection. But the rule of having the marking within 1 centimeter and creating that phantom target is very important to get a good signal, number one, and two, based on that, from this image, I'm not saying you have to put 3, but you should know which one you should pick when you are discussing that with the thoracic surgeon. The second thing, we're looking at different coronal and the sagittal. With the discussion, you know that it's important to know if I put it up here or here, make a difference. This is a case of a posterior lesion on a patient with adenocarcinoma, as you said, and we planned this location because the cut line coming that way, as we understand it when we discuss it together with Dr. Cedeño. And the advantage of using the planning platform is very important when you have the option to make a 360 round around the target and the phantom target, as you see here. So in this video, you can see that the phantom target is staying next to the pleura, even when the patient on the side, and then again coming from here, and the cut coming from the hilum toward the peripheral. That's why the first thing you need to see the signal, so you know that the target is behind it. And based on that relationship, the margins can be protected, that whatever behind my signal is our target. So how to mark a lung nodule? So a simple survey done on social media in different platforms, and you can see that we still having a big population. The voters not too much high number, but at least get a sense from who better put any who is doing that marking for subglobal resection. More 80% still using and will still using, which is the marking with the needle, especially if you are doing it the same day, and 20% considering the coil with the ICG. For our model, we use the real-time imaging as using the O-arm. That's what we have available. And whoever using the O-arm knows that we have to position the patient in a specific height on the bed so we can lock on it and have the spin happen. So you don't worry about clearance after you closing the O-arm around the patient. And then that's the simple finding after having the ion or the robot connected to the other side of the patient, the O-arm locking on that side and the XI on the other side of the room, waiting for us to finish the marking. This is a paper for Dr. Krishna that highlighted the technique of soaking the fiducial with ICG, and we used it here too. We have used it since December, and we had like 17 marking since then. This is the example of the same case, and as you see here with the O-arm, we changed it to the lateral and deploying the fiducial coil next to the lesion. At the same X-ray here, you can see there is a marking from before, and this is the fiducial that we placed at the beginning of when we diagnose the patient, with intention that the patient might not be a candidate for surgery. But then when we reviewed all the PFT, PET scan, we saw that this is possible. And it helped us, especially when we understand that we want to put the marker at the side of the lesion, that fiducial played a big role also for us, even that we used the O-arm spin when we did that to show where is the coil to the lesion. And this is on the axial, this is on the coronal, and this is on the sagittal. But having that there with the understanding where we know that the patient will be positioned, that's where we position the patient. And this is a confirmation, the same video, but showing you where those coils were located. Now, the same case, after dissecting and clearing up the pleura, you can see now this is the signal we're getting. And we know is the tumor from what we placed is more out because we got started from the hilum. Here, where the benefit of knowing when you're cutting the tumor and knowing where is your marker. And this is where the marker playing a role. We know what is the relationship before the case between that marker, as you saw on the O-arm spin, or even from the phantom planning case, it is more medial, and that's where is your cut coming from. So if we continue cutting laterally, we are including the nodule with the free margins. This is another confirmation after making the first cut that still we are posterior, we are getting the signal, and the tumor is on top here. This is the data that we have now, and you are welcome to hopefully visit our abstract on the next AABIP meeting. We have a total of 13 patients that have total of 17 marking. 2 patients has one of them 2 marking, and 3 has 3 marking. What we learned from that 1 centimeter rule, because one of those marking, we did not see a signal. And we're so honored to share this with you because we don't want this to happen to anyone on the audience without knowing how we learn from each other's mistakes. The other thing, we should avoid placement within the lesion. Any lesion that, even if you have the CAT scan that was long time ago, maybe if it's even kind of ground glass, it can get more solidified, and that you can still get the signal, but it's more fade than what was as wished to be seen. And also, it highlights that how from then we discuss every case with the planning prior to putting that. We do it the night before, and then we make sure that all of us on the same page where this fiducial or this marking, either with needle, fiducial, or any marking should be done. So we did around 17 marking. What we like to share with you is the marking time. That's it's usually really between 23 minutes per marking, but even with those cases with 2 or 3 marking, it was not more than 40 minutes. But more important, the turnover, by doing these cases more and more, it was become a learning curve for the staff in the OR to shorten the time, because now everyone knows the role, everyone knows what the next step is. So it was a great mix between endoscopy staff and OR staff to make the turnover happen quick. The robotic goes out, the patient turn, anesthesia do the A-line if they need to, single lung intubation, and then move on. What is we like more is the resection time that also reduced. That's including the lymph node dissection, 40 minutes plus minus 6, and also the free margins. Most of the patients we do them, as you know from the paper, less than 2 centimeter. So the margins always has been average more than 1.5 centimeter. And the length of stay, usually 1 day, except if the patient has some kind of socioeconomical issues or has needs support at home, that he's living alone, so we keep him 1 extra day. But the total OR time now going around 100 minutes. And for 2 procedures at the same time, bringing the patient to have a cancer-free in 1 shot, that's what we are so proud about. This our work presented in multiple international, in Italy and in India, about that model of single lung intubation. If you need to learn more about the lung and the marking, please visit the YouTube channel. And now I'll move the mic to Dr. Cedeño for his part.
Good evening, everyone. So basically, my part is a little bit like more like the technical part. I have no disclosure. Basically, from all the objectives that we have discussed, I will put more attention to highlight the type of marking technique on the anesthesia event, the modification of the marking technique that we have used to accommodate the best signal during the resection. And basically, that comes along with the consideration of what is the closest point to the pleura. And that's where the 1 centimeter rule that we are talking about constantly, because it's extremely important. And the role of real-time imaging for marking with robotic bronchoscopy with the use of the O-arm is extremely helpful, as it is a very accurate marking. This is just a quick summary. As we all know here, that lung cancer is the leading cause of cancer death. But we are trying to improve survival, and we have done that through improvement in the lung cancer screening programs, and that basically make that we have been identifying more and more cancers where the tumor is less than 2 centimeters. Having said that, in lung cancer nowadays, there's no rule of like one fits all. So what I mean by this is like every single patient, when it comes to the office for further discussion about surgical resection, Every single patient is different. Every single patient has different comorbidities, and every tumor is different. But these are basically the armamentarium that we have to treat lung cancer, or surgically speaking, I should say, that goes from pneumonectomy to sublower resections. When we talk about the realm of sublower resections, there are two different techniques. We call it segmentectomy. We call it sometimes what we call anatomical sublower resection, and the famous wedge resection that are not anatomical per se. With that in mind, there are certain things that we really want. So first of all, we want to provide a curative surgical resection. That's very, very important. Nowadays, we want to preserve as much lung parenchyma as we can. And the reason for that is because we know that we can preserve more lung function of the patient. That turns to have a patient who has a low or a surgery with a lowest or a low morbidity and a low mortality. That also enhances the possibility of future resection, especially when we find or identify patients who are on the mid-50s or early 60s who has lung cancer, that the possibility that they might develop another primary lung cancer within the next 10 years or so is on the higher side, so we can enhance the possibility of future resections. That's without saying that we want to make sure that the overall survival and the disease-free survival that we currently have in lobectomy is equivalent to the lobectomy group. And the other thing is that we want to see if we can offer surgical resection to more patients. That probably that patient that might not be able to tolerate a lobectomy, we can offer him a sublower resection with good overall survival and good disease-free survival. Having said that, just a little bit of background why lobectomy was the gold standard. It was because of a study from 1995, we call it the Lung Cancer Study Group. In that study per se, they compared lobectomy with limited lung resection. Basically, that's a wedge resection on this article. And at that time, it was the conclusion were that the local recurrence on the limited resection group was 3 times higher than the lobectomy group. And when we talk about the overall survival, it was reduced by about 30%. With that paper, it was concluded that lobectomy should be the gold standard on any patient who has primary lung cancer. Now, do we have any randomized control trials since 1995? Well, we have 2 of them that were recently published. One is a Japanese trial, the other one is a North American trial. In the Japanese trial, it's a multi-center non-inferiority randomized control trial. The data was collected from 2009 to 2014. This one is the largest trial from the 2. It's a little bit over 1,100 patients. In this specific article, or randomized control trial, they only compared lobectomy with segmentectomy, but there were tumors that were less than 2 centimeters, and the primary endpoint was overall survival. In the North American group, they, based on a Turkey group, they said that they want to be more on the what they call the real life experience in North America. So that's the reason why it's a longer trial. It's about 10 years long. It's 697 patients, and in this one, the sublower resection included the wedge resections and included also the segmentectomies. And from the arm of the sublower resection, the majority of them were wedge resection, but it was the same criteria. So it was tumors that was on the periphery, tumors that were less than 2 centimeters, tumors that were non-small cell lung cancers, and tumors that we already know and has a proof that the mediastinum is completely negative. So those were the criteria. And again, the primary endpoint was the non-inferior disease-free survival. Both articles, they brought the same conclusions, that sublower resection is non-inferior to a lobectomy. But again, there are specific criteria. Tumor has to be less than 2 centimeters. Tumor has to be a peripheral nodule, and they have to be node negative in order to be considered for this type of surgical resection. And basically, this is the article. So we are more trying to transition to more for sublower resection. Having said that, even though we are trying to transition to more to a sublower resection, more importantly is that every single patient is different. So the surgical decision that we create is based on every single patient as an individual, depending on the patient risk factors, depending on the patient comorbidities, depending on the tumor that we're treating, depending on the size, so on and so forth. With that being said, given the fact that we are identifying tumors that are small, it is becoming more difficult for us as surgeons to using minimal invasive techniques, because we don't use our hands per se. We use instruments, especially on the robotic platform, to identify these small nodules, especially if we are resecting a patient who has a ground glass opacification, who maybe has a 5 millimeter density inside that ground glass opacification. Having said that, we have trying to find techniques where we can mark the nodule that we can see using the technology that we have. And interesting, this is an article that was published in the Annals of Thoracic Surgery in 2015. And since then, they have been trying to see if the use of ICG is something that is feasible. And since then, we have proven that it's something that is feasible. Recently, on an article from 2023, the use of the ICG has been very popular in the thoracic surgical field for many things. We use it for esophageal surgery when we do a segmentectomy and we want to demarcate the area that is already not perfused, because we already removed some of the vessels that perfuse that segment versus the rest of the lung. We use systemic ICG, and now we are also using the ICG to specifically mark the nodule of interest. In this particular is a non-randomized controlled trial. So basically the category of using this is a category 2A. Now, more importantly, how do we prepare in order to get to the surgery? So I cannot like use this first bullet that I think probably is the most important one. There has to be a close collaboration between the surgical team and the interventional pulmonary team. All these cases, they need to be planned together. There's no way around it. The thing that we have learned throughout the process is that first we have to imagine how the lung will collapse. In addition to that, we have to know what is the closer region to the pleura. We also have to take in consideration like the resection margin. Well, this is the location where I will start my resection margin. So basically, this is the location where I think we should start the marking so we can get enough margin. Because again, one of the most important things is not only the sublower resection, but more importantly is that we have adequate margins for the resection. And that's where we concluded that the target that we are going to create should not be deeper than 1 centimeter from the parenchymal margins, because you have to think that when you put the marking, you are looking everything from the inside, but when we enter the chest cavity, we're looking everything from the outside. So that's why when Dr. Alraiyes said that the lesion should not be marked proximal to where the nodule is at, that's when we identify that basically if we want to see the nodule from the outside, it needs to be the closest to the pleura as possible. And that's when we came to the idea or the technique of creating a phantom target. This is just the same sketch that Dr. Alraiyes created. This is just one of a few examples that we have. So the first things, we have to imagine how the lung will collapse. As you can see in these images, the lungs always collapse towards the hilum. This is the nodule of interest. At the same time, we have to identify what is the closest region to the pleura, which is basically this area here. This is how the lung will collapse. This is the closest region to the pleura that is marked in purple. So basically, the closest region to the pleura, the way that the lung will collapse, and my resection margin will probably start on this location. So that's why the phantom target was here and not on the lateral side, because that's the resection margin. If we make an exercise so that this is how interesting how we see the case in the operating room. So the patient is on the lateral cubitus. So basically, in that same location, pleura is here. This is a phantom target because this is the area of resection or area of interest that I'm planning to perform. This is a sketch of exactly the same picture that we just had. In the operating room, we have all this technology, but basically this is what we see on the fluoroscopy guidance. As you can see, this is where the phantom target is basically placed. Again, this is a coronal view of how, just to make it more like interesting of how we really are seeing the images in our head. Phantom target, because this is the area of resection. And more importantly, the following slide, because this is exactly what we see in the OR. Now, this is all the images combined. So this is a coronal view. This is how we see it in the operating room. See where the phantom target, where we place it, because this is the tumor of interest. This arm that we have here, because this is the location where the stapler line will come through. So that's the reason why we mark the lesion here, because I know that if I go deeper and proximal here, I will get plenty of margins, and it will be, I will have like a good amount of negative margins. And again, this is the surgical resection line. This one is a small video. Again, we're looking here. This is just for a purpose of the presentation. This is the location. The tumor is somewhere around here. This is the location where the stapler will go. We'll move a little bit forward here. This is basically just identifying where the resection will be performed. I think this case was going to be a wedge resection. And then basically just to make sure that that's the area of interest. This is another example. Same idea. This is where we mark the tumor somewhere around here. And basically that's how we plan the resection margin. Again, same concept. In this one, I just highlight the importance of the ICE. This is a segmentectomy. This is another case, and we use systemic ICE to demarcate. Basically, this is the area where the coil was placed. This is after all the vessels were resected, and this is basically where basically the perfusion area versus the perfusion area versus the non-perfusion area. So this is basically the surgical resection margins of the apical segmentectomy. Same idea. We use some because we are using different, what we call it, firefly technique. So I burn the lung parenchyma just to guide myself. This is how it looks on the high quality images that we have. Just at the resection margin. This is how we do it. Same, just to prove that we have the coil inside the specimen. And this is how it looks in the pathology. So we have plenty of margin. The margin is up here, because this is again, it has to be a peripheral tumor. And this is another neat view. So the reason why when we talk about like being something, so basically the pathology start cutting the specimen this way and then that way, so that you can tell that the coil is side by side where the tumor is at, but closest to the pleural, so I can see it, or so we can see it using the robot. That's the tumor, that's the coil. This is another case. Again, this is the lateral portion. The tumor is somewhere around this upper portion up here. So stapler will come that way. That's the reason why the coil is down here, but the tumor is up here. So I know that I have a wide margin of resection. Again, coil here, tumor up here, side by side. And this is basically the sublobar resection there. So again, as a summary of the presentation, there has to be, it's extremely important to have a very close relationship in between the surgical team and the interventional pulmonary team, so that we can make a proper diagnosis and staging. We basically take the patient to the OR for a sublobar resection when we know that the patient is the right candidate for it. And tumor less than 2 centimeters, that we know that the patient has a negative intestinal staging, the patient has the PET CT, that the patient do not have any distant metastatic disease. So this patient is basically stage 1A1 or 1A2 lung cancer. So basically we eliminate the risk of marking patients that after talking and after doing all the preoperative workup are not surgical candidates. We discuss with the patient what is the benefit of having a single anesthesia event. The anesthesia time, as you on the presentation of Dr. Alraiyes, basically the entire procedure, it takes about 100 minutes. Our resection times, including the mediastinal lymph node dissection, it's less than an hour, and it reduces the hospital stay, and the patient do very well. The challenge that we encountered at the beginning, and we're still encountering, though it's getting better and better, is that it's a two-team approach. We have the bronchoscopic team plus the surgical team, so we have to work in a collaborative way. Dr. Alraiyes has all the navigation bronchoscopy system, the O arm. We have to get that inside the room, get it out of the room, switch to the surgical field, The patient has single lumen tube, and then we have to put a double lumen tube, etc. So the process of having two procedures at the beginning can be challenging, but it's important to be patient, just to trust the process. It will get better, and we're getting faster and faster as we move along. And thank you for your attention. And basically, this is a picture of the entire thoracic team.
Thank you, guys. This was a great lecture. Looks like you have a great team there. Awesome people. Thank you so much. This was very well constructed and a dual work. I'm gonna start with the first question. This has been an awesome talk, and I enjoyed every bit of it. So, how did this change your practice? And my question is for you, for both of you. I mean, especially the logistics, which seems like it's a nightmare, but like, you know, I mean, thinking about all the details, the height of the table, and you know, how did it change how you approach those patients?
I'll start with that. Yep. So really, it's more important that you can think that the first case we did in January took us like at least 45 days to prepare the team to understand what you're doing. And remember that not every time you have the same exact team from either endoscopy or bronchoscopy team with the same OR team. So until everybody overlap, it takes time to have that coordination. However, starting as a first case, always a big advantage of the day. This is better than if you are starting in the middle of the day, because everybody, almost like you're taking the first flight of the day, you know that there's no delay. You're not waiting for a flight to come in to take off. And that's where the challenge would become if you're doing the case in the afternoon, for example, because you're waiting for the other team to be prepared or the room to be done, to be turned over from other surgery to do that, for example. So we learned that having the first case of the day for marking is the best thing. The second thing, from the bronchoscopy point of view, I'm talking, the second thing, we started, for example, posterior cases. Every one of us, there's a high risk of developing atelectasis. Even implementing the anesthesia protocol for those patients with high PEEP and tidal volume, F2 for less than 40, all of these things, we were, the anesthesia, were starting putting the A-line, Foley catheter, another IV before we start our bronchoscopy, for example. So what we eliminated, we asked them to do that part in between the two cases. So at least we avoid atelectasis and make sure that we marking exactly where we want, instead of the atelectasis will make it hard for you to know where to put the marker. That's from bronchoscopy, but I will leave it up to Cedeño now for the second part.
Yeah, I mean, as everything, like you have to prepare, like try to organize things for success. We knew that when we were going to start this process, there will be a lot of roadblocks in the process. So basically, what I did is like we tried to find a 7:30 start, and even though it sometimes is challenging for us, basically the first case, that was the only case of the day, and we tried to find a case that was easy enough so we can troubleshoot the problems. So to have a upper lobe nodule, a nodule that is basically on the periphery, a nodule that if the patient, even though the patient, we offer the patient a sublower resection because they meet all the criteria, in case that we missed the marking and the patient will need, for example, a formal lobectomy, that the patient could tolerate those things. And we prepare our staff for it. We talk to the bronchoscopy people, we talk to the OR, we tell them this is the plan, this is how we're going to approach it, this is the instrument that we need first. After this is done, we need to have 20 minutes, and we put a clock in the OR. So we have 20 minutes from the bronchoscopy, innovation bronchoscopy items to be out of the room, and that the operating table is already open and ready to go for the surgical one. At the same time, anesthesia is changing the tube to a single lumen, from a single lumen to a double lumen tube, and nurses are placing the Foley if needed, so on and so forth. So we try to organize everything in those first few cases so that we can have success. Our staff trust the process, anesthesia trust the process, and the more we do, the more it's becoming more like a second nature. They know like this goes first, this goes second, this goes third, patient goes out, this goes in, and then we keep the case going.
Awesome. I just want to remind the audience, if you have any questions, to submit it to the chat box. So we have a question. I know you mentioned this in the beginning of the talk. What are the challenges, pitfalls that you, Dr. Alraiyes, have experienced with lung marking via ion robot?
Oh, the challenges mainly is like what usually you face, especially if learning curve for the anesthesia to know your protocol. That's a major one, especially with atelectasis. But really, this become very easy understood the moment they see down the robot in the room. They know that this is the robotic protocol, except if we have somebody never did it before. So communication again is the key. Always before I ask about what we are doing today, I ask who's our colleague from anesthesia doing it, because I can confirm and go over questions immediately. The second part is the more important is not knowing. In the beginning, we thought like we throw that, you put it and you go to the lesion, you throw the marker there, needle, push, or marking with fiducial, and it will light up like right away. And then we discovered that, oh, wait a minute, this is biologic, is not next to the pleural. I am putting it inside a solid nodule. How come this gonna light up down the road? So that's immediately after like first case happened to us, we went over troubleshoot why this did not light up after turning the patient. So one, avoid proximal placement. Do not go with the airway that, yo, I'm happy I see my lesion if it's like even 1 centimeter, but if it's 1 centimeter and it's already 1 centimeter away from the pleura and you place your marker there, you are already 2.5 centimeters away from the pleura. That's where the challenge can be. The second thing is, if you are putting it on the other side where the forceps or the cut coming from, because now how you guarantee that you are cutting, because think about wedge as going sideways. So you want your marker at the narrow angle to go to the wider angle, so you guarantee free margins. So if I put it on the other side, of course, yeah, I'm happy. Oh, it's lighting up, it's excellent. But then you are cutting, and then, oh, should we send for frozen? Is it including the whole margins? If it's not, what happened is now we didn't have any case without free margins, but it was challenging to know, maybe you need to cut deeper now to guarantee that the tumor is in. So to minimize the loss of the volume of the tissue was that two techniques to be where we want to put it and avoid lesion, avoid proximal, go with 1 centimeter rule.
Oh, awesome. Do you happen to communicate certain, like let's say you had difficulty in approaching an angle, you tell Dr. Cedeño, like, look, I'm not really confident about this one, you may want to, is that something that could be interchangeable during the procedure?
You can go ahead with that.
Yeah, that's the reason why we anytime that we think that we want to mark a patient, we plan the case before the surgery. We try to get it done the night before, just to make sure we have the planning the way that we want it, and we basically discuss this is how I think that resection will do, or I think this is the segment that I will take out. This is where I think it should be done. And because it's a phantom target, we have it doesn't. We want it accurate, but it doesn't have to be very specific. It can be like a little bit lower. The important thing is that it has to be within that same quadrant of where I think the resection, where I know the resection will start.
And the second thing, the real-time imaging is the key. So the maximum numbers that we did for a spin was 2 spins, sometimes 1 spin, and we're done. We know we're putting there, we're happy with it. But in the first cases, we were doing another spin at the end to make sure that we place it in the right spot.
Yeah. And we have found that real-time imaging is literally what helps be very accurate on the process.
Awesome. I have a question from the audience. I know they mentioned publications during the talk. Do they have any publications specific to the way they schedule, plan, and organize their cases?
It's a new things we're doing. We are, as I mentioned, the abstract going to be at the ABIP. Hopefully it get accepted, and from there we're looking for sharing that model. I'm not saying this is, again, this is an experience where I have the luxury that I'm working at the same department with thoracic surgery. It's not applicable everywhere, of course, but happy to share it to see if that can create. I think we are living now in a way that really that collaboration is very important. And that's what, if we will do something, we'll highlight that collaboration.
We look forward to it. Stay tuned, audience. We have another question. Do you feel that the special characteristics of the ion robot in detecting the proximity to the pleura had helped or made you feel more confident when you're approaching questionable lesions like subpleural or you know, those in nature?
That's very interesting, because sometimes I'm Dr. Alraiyes telling me, "Hey, Alex, I think I am very close to the pleura." I think, don't worry, we no matter what, we have to enter the chest, so go a little bit further out. And usually, even though the machine tells you that you are within 1 centimeter, usually the machine trying to be safe. So even though it says 1 centimeter, usually you are more proximal than what it really said. So usually we push the catheter just a little bit further, and that's what really helps.
Using the technology, not the technology using you.
Yeah, and then the other thing is that you have to remember that when we put the lung ventilation, the lung will drop. So you have to be very careful that you keep that the coil is at the parenchyma, not at the airway, because when the lung drop, chances are that the coil will probably migrate proximal. And that's something that it happened to us. One, we were lucky enough that we were able to get the resection with a segmentectomy and everything was okay. But we were able to identify that that's one of the troubleshooting that we have encountered. So we decided that what is important is just to always put it at the parenchymal level, and it's always a little bit more towards the periphery.
Okay, well, awesome. This is it for the questions from the audience. And again, thank you so much, AB and Dr. Alraiyes, Dr. Cedeño, and we'd love to have you back. And we are present in ATS, so register for our talk, and if anyone is attending, we'll be happy to see you there at our booth. Again, thank you everybody for attending, and I'll see you next webinar.
Thank you so much.